Thank you very much, Laura, for this very comprehensive overview of what AMH can do for us to ovarian stimulation. It's now my huge pleasure to invite the chairman or the organizer of this Congress to come on stage one more time. I don't think there's any necessity to introduce Human Fatemi anymore. Human is going to address us on the poor responder. Are there any new treatment options available in 2018? Human, the floor is yours.
Thank you very much, Klaus. I'm going to try to keep it short because I know you're tired. Too much information on a very short period of time. But I think poor responder is a topic which is interesting for all of us because we are seeing more and more about these poor responders. You have seen this slide before. Different age categories, women can have different responses, but age is not a predictor of response only. How do we evaluate and anticipate the response of a certain patient? Obviously, we have the ultrasound. We can do the antral follicle count, the ultrasound machines we had in the past, the ultrasound machines we have today. And today, we, of course, have the feasibility to do the 3D scan, and it's very clear how to assess the ovarian reserve. Unfortunately, part of this slide is missing because of incompatibility with the MAC. But what is showing that actually both the antral follicle count and the AMH, as you have seen from Dr. Laura's presentation, show significant inter-cycle variations. Now, also this slide unfortunately is missing, but this is just demonstrating the significant variation of AMH within and between the cycles. You also have seen this slide from Laura, which we just published recently, that there are up to more than 20% of variations of AMH within the cycle. It means we are having antral follicle count, which differs significantly between the cycles, and we have the AMH, which differs between the cycles and within the cycle. The problem is, if you speak about a poor responder, you will face and you will see a lot of studies which have been published. Many, many studies are out there. But imagine you know that the cycles and the antral follicle count and the AMH vary significantly between the cycles. What is the objectivity of evaluating a certain drug if it's having benefit or no benefit at all? Furthermore, if you take a look at the heterogeneity of all these studies which were looking into the benefit of a certain drug, you see that there is a huge heterogeneity among all the studies which were conducted. It means today we don't have a clear answer what is really good and what is not good. What we know is if you put all these factors together, the antral follicle count, the age, the AMH, if you put that all together, you have a pretty good factor of response, excessive or poor response. So we have tools combining all these things together in order to have some kind of prediction of response. Why is it important to predict the response? Obviously, you want to avoid this and this. So the ideal curve is to have a certain number of eggs. What is this number of eggs? I don't know. But we want to have, 13, 14, 15 eggs to have the highest chance of a pregnancy. So we want to eliminate the extremes being poor responders and extreme high responders. Of course, the live birth is directly related to the number of eggs, and this is again related based on the different age categories that you're looking at. So based on what age you are at, you can anticipate what is your chance of having a live birth. Here you see the distribution of the number of eggs being retrieved in ART. As you can see, we are dealing with approximately 20% of poor responders or low responders. But this prevalence, I can tell you, differs based on the country you live and work in. Here in the GCC countries, we are observing much more these kind of patients than anywhere else in the world. The problem is if you become a poor responder and or you are becoming older, what will happen? You will also generate more chromosomally abnormal oocytes. Independent of age. Independent of age. Anti-Mullerian hormone or ovarian reserve is a predictor of having more chromosomally abnormal embryos. With other words, a 25-year-old lady who has an ovarian reserve, let's say of anti-Mullerian hormone of 0.3 nanogram per ml, as compared to a 40-year-old lady who has an AMH of, let's say, 3.2 nanogram per ml. The young lady has a higher probability of having more abnormal embryos at the end than the older lady. So this is why you cannot simply say age is a certain predictor of outcome. It's not. Because you can have a young woman with a low ovarian reserve and you can have an older woman with a good ovarian reserve. And these are the two publications which have been published, and I'm happy that Teddy Tadros, who contributed to this work, is present in the room today. Now, poor responders, the definition is also very difficult. It's a very heterogeneous group. Generally, we have agreed on less than 3 to 4 oocytes retrieved. But then less than 3 to 4 oocytes with a 40-year-old, with a 30-year-old, with a 25-year-old. So as you can see, it's very difficult to have an objective evaluation of the poor responder. Definitions have varied over the past. People have looked into the eggs, people have looked to FSH or estradiol, and so on and so on. And if you start looking around the world, how do we treat those women who we define as poor responders? Also there you see there is a huge heterogeneity. Now to solve this issue, Escher came out with a certain proposal, and that proposal has been published called the Bologna criteria, and they said, look, basically you need to have 3 or less number of eggs, and you have to have a low AMH of less than 1.1 nanogram per mH. So, but again, that has its pitfalls. It's not really perfect, the definition of the Bologna criteria. But one point that everyone agrees on is those patients, those poor responders, they're not doing well. If you take all the studies looking into the outcome with the poor responders, whatever you want to do, they do not do good. The chance of having a live birth per cycle, 6%. Extremely poor. Why? Because the lower the number of eggs, the lower is your chance to have a genetically normal embryo. Now, to complicate those things more, this publication came out, the so-called Poseidon classification, saying, look, you can be a young woman, but you can have a good antral follicle count, you can have an acceptable AMH, but at the end, you will have less number of eggs. So these values are okay, but for some reasons, you don't respond well to the stimulation. Or if you are older, the group 3 is if you really are into this Bologna criteria. So here, they're stratified into 4 groups. Now, generally, we know when we have a poor responder, what do we like to do? We like to bombardate the ovaries with FSH. So we push and push because we think the more the better. Is that the truth? Maybe not. Because if you start stimulating on cycle day 7 and you reach an FSH value of 22, it doesn't make any sense to go more than that. Because reaching that value means you are covering all the receptors. Nothing else will happen. If you have 2 lockers and I give you 5 keys, you can only open 2 lockers, not 5 lockers, because there are only 2. So if you have a certain number of receptors, and this is what's happening, you're covering them all with an FSH of 22. We know that low responders do not have any differences in FSH receptors as compared with normal responders. But what we know is that women who are getting older, they have a change in endocrine profile. We know that those women have a decline in testosterone, DHEAs, free testosterone, androstenedione, but the sex hormone binding globulin remains stable, no change. So knowing that, the first thing what you might say is maybe those women might benefit from the co-administration of androgens or testosterone. We know, for example, that there is a direct correlation between FSH receptors and androgen receptors, which means the higher the levels of androgens, the more FSH you generate, FSH receptors, and that would be beneficial. This is exactly, for example, how letrozole, an aromatase inhibitor, is working. By blocking the estradiol production, accumulating the androgens, and increasing the number of FSH receptors. We know if you do an ovarian cortex transplant of a female mouse into a male mouse, and you stimulate the female and the male mouse together, the male mouse will have a much better response than the female mouse. Maybe we should get pregnant in future. So as you can see here, androgens seem to be better for response because the male mouse has obviously more androgens. And this is why the male mouse is responding better to stimulation. Now, having this basic knowledge, we know that transdermal testosterone is essential substrate for estradiol and 2-cellular gonadotropin theory. And this is also why it has been proposed to be used in poor responders. Many, many studies were conducted, and at the end, the conclusion was that actually, yes, you can apparently significantly improve your clinical pregnancy rate and also your live birth rates. I can tell you today that there is a big study running in Europe looking into transdermal testosterone. Most probably that will more reinforce the findings that you see here. What about DHEA? Because very often we see patients, they come to us and they all take DHEA like chocolate. So everyone loves DHEA for a reason of poor response. The question is, what is the validity? What is the evidence? What is the scientific evidence behind the administration of DHEA? Obviously, it's similar to transdermal testosterone, and it increases the IGF-1 in patients undergoing ovarian stimulation. Now, initially, Dr. Norbert Gleicher and Dr. Barat published a paper that actually DHEA works greatly and it improves everything. Many studies came out. Some have taken some patents on those products. Dr. Gleicher, I think, has a patent on DHEA in the field of human reproduction. And more studies were conducted. But actually, further studies which were conducted, they failed to find out any benefit of the co-administration of DHEA. There were more studies coming out, and most of the studies which came out, which were verifying independently the response to DHEA in poor responders, failed to reconfirm the initial findings. Hype or hope? It seemed to be hype. Now, what about the different modes of stimulation? REC-FSH, HMG, long agonists, antagonists, season of treatment, and so on. I will go briefly through everything that we have, but as you can see, there seem not to be any difference. GnRH antagonist versus agonist, if you take all the values together, there is no big difference. Now the SPARK trial. Some have come with an idea that LH administration would benefit to those patients. This is a big prospective randomized controlled trial, which was published a year ago, and also there, they didn't see any benefit in more than 800 patients if you would add any LH to your FSH in those poor responders. What about continuing the downregulation or ceasing the downregulation? And this is a paper we published with Dimitra Kiru. Dr. Garcia Falasso contributed to that. Also here, no difference at all. What if you bombardate the follicles with a lot of FSH? You have seen if you reach 22, doesn't make a difference. So if you compare 300 units, 450 or 600 units, look at the end. Number of embryos, cancellation rate, live birth rate, non-significant. So should we push the follicles too much? I don't know. What you see here, it doesn't make any benefit if you give too much FSH. There's a recent publication from Dr. Braulio from Alain where they demonstrate actually if you give too much FSH, you might even jeopardize and have more chromosomally normal embryos. What about comparing short agonists with natural cycle IVF? The results are absolutely comparable. Now, something interesting is the growth hormone. So except transdermal testosterone, it seems that growth hormone is also beneficial for poor responders. Why? Because it's also working on insulin-like growth factor 1, which is beneficial for steroidogenesis. And if you take a look at studies conducted, you see there seems to be a significant difference in favor of growth hormone administration. Do we use that daily for our clinical work? No, we don't, because we have lack of evidence on the safety of that drug. And again, heterogeneity. If you take a look at all the studies which were conducted, 25 units, alternate days, 12 units, alternate days, 0.1 kilogram, whatever, you see there is a huge heterogeneity on the studies which were conducted. There is a huge variability on inclusion criteria and treatment modalities. More recent studies looked also, again, to the co-administration of growth hormone, and they also see some benefit of the co-administration of growth hormone. Recombinant versus urinary, also that has been studied, and it seemed, again, not to make a significant difference. Now, this is a study which was published a couple of years ago in Fertility Sterility. They said, look, if you have a poor responder and she has, let's say, only 2 embryos, why should you wait to day 5? Just transfer them as soon as possible. And they showed that actually the earlier you transfer with the poor responders, the better it would be. On the other side, we know that those poor responders generate more chromosomally abnormal embryos. Would it be not better to verify and make sure that you are transferring a chromosomally normal embryo? A more recent hype is the introduction of the dual stimulation, because you have heard from Laura that you can stimulate at any given time during the cycle. The recruitment of these follicles occurs actually at any given time during the cycle. We know from cancer patients that we can stimulate at any given time during the cycle. Based on that assumption, Kuan came out with a publication of the dual stimulation, that you stimulate a poor responder, you vitrify your eggs or your embryos, and immediately after the pickup, you can stimulate again. So basically what they did, stimulation, trigger, pickup, again stimulation, trigger, and pickup. It means within one cycle, you can harvest twice the number of eggs, which is a good idea, and it has been studied on various occasions, and also Filippo Ubaldi confirmed it. This is one of his slides, where they stimulate one cycle, and in the luteal phase they stimulate it again. They also looked into the genetic information, and they didn't find any more abnormalities in the luteal as compared to the follicular phase. But what is interesting to see here, some women have less eggs in the first cycle and more eggs in the second one. Sometimes it's the opposite. So it's not that you have always the best response. And this comes back again to intercycle variation. You will not always have the same number of eggs. So sometimes you have a certain number of follicles, and it might be that the next time you have less or more. And this is exactly what you see in these slides. Now, this is a topic which Professor Pellissier spoke about, and I think he will be speaking about. Ovarian rejuvenation is actually an idea which was initially from Japan, activating women with premature ovarian failure through the hypopathway, cutting it out, activating it, and putting it back. And what they described actually, that by doing this, they would reactivate the ovaries. Now, personally, I have my doubt whether this is the activation of the hypopathway or whether this is just an aseptic inflammation of the ovary by surgery. Just taking out the ovary and putting it back, you generate what we call an aseptic inflammation. You generate neovascularization, there will be more blood supply, and maybe that is the reason why these women had temporary an activation of their follicles. So to conclude, I think for the time being, we need to have a clear definition of poor responders. Today we have the Bologna criteria, we have the Poseidon criteria, but actually it's a very heterogeneous group. From all what you have seen, I think today, according to evidence-based medicine, transdermal testosterone is something which seems to be beneficial. It's Advised to administer it 6 to 8 weeks prior initiation of treatment, which means that you should actually treat it before you start stimulation. We know that growth hormones seem also to add a benefit, but again, safety question mark, it's very expensive, and big heterogeneity in the studies conducted. If you rely on the lab, I would go to day 5 genetic testing. If you do not rely on the lab, then maybe you should transfer as early as possible. Thank you very much.